All right, well, maybe I'm going to start by taking attendance and seeing who's on the line and on Zoom. We're going to start with introductions here in Vancouver at Legacy Creek, Legacy Salmon Creek Hospital. We're hosted by Lori Wakashigi. So I'm John Scott, University of Washington. And Lynette, do you want to introduce yourself and we can go around the table here?
Sure, my name is Lynette. I'm assisting today. I actually work for the Chief Health System Office in University of Washington. You got that.
Hi, Brody DeChinko with Cambria Health Solutions, Regents Blue Shield.
Representative Schmick, 9th District.
Lori Wakashige, Legacy Telehealth and Regional Outreach.
Okay, great. And then we're Stafford, do you want to introduce yourself?
Stafford Strong with the Center for Public Health.
Great. Let's go to the phone. I know we had Danny Lorden who's driving and he introduced himself. Can I see who else is joining us on the phone?
Hi, John. It's Stephanie Cowan at Multicare.
Hi, Stephanie. Thank you for joining. I see Cara Tao also.
Yep. Hi, this is Cara Tall from University of Washington, Department of Psychiatry.
Great. Thanks for joining, Cara. And while I'm thinking of it, I want to wish all of our nurses who are joining us today, including Cara, Happy Nurses Week.
Why, thank you. I didn't even realize.
You have a whole week. I also see Dr. Joshua Frank from Confluence. Dr. Frank, can you hear us?
Hi, John. Yes, I can. From
Great.
American College of Emergency Physicians as well.
Okay. Glad you could join us. Let's see, we have Ian Goodhue from University of Washington. Ian, do you want to say hi? All right, Ian's probably taking a phone call. Lisa Roche from Providence.
Good afternoon.
Hi, Lisa. Let's see, I'm just going to go take attendance now. Do we have Senator Becker on the call? Well, hopefully, I know Senator Becker was going to try to join us. Hopefully, she'll join us soon. Do we have Chris Cable from VM? No. Senator Cleveland. We had Stephanie. Kathleen Damon, are you there? Nope. Okay. I know Joelle Fotley was going to call in around 2 o'clock, but she was unable to join right at 1 o'clock. She's out in Wenatchee. Chad Gabelin from Virginia Mason, you online? Nope. I know Dr. Guff can't join us. Do we have Sheila Green-Shook? Cheryl Huchala?
I'm here.
Hi, Cheryl. Glad you can join us. Dr. Jimenez, Dr. Ricardo Jimenez from Seymour. Nope. Dr. Jones, Jeff Jones. Nope. Do we have Dr. Kie? Also, I think from Washington Emergency Physicians. Scott Kennedy. Sarah Orth. Nope. Adam Romney. And do we have Representative Riccelli, Marcus Riccelli? Okay, well, great. I think there's a couple other phone numbers here that may have not introduced themselves. If you want to please unmute yourself and tell us who you are, that'd be great.
Hi, this is Lori Lippold with Partners for Our Children and a member of the Children's Mental Health Work Group.
Okay, great. And you said it was Lorinda? Lori.
Lori.
Okay, hi, Lori.
Yeah, thanks. Hi.
Marissa Ingalls, Coordinated Care.
Hi, Marissa.
Hi, everyone. This is Gina Rosengaus with the telehealth team at UW Medicine.
Hi, Leah. Thanks for joining. Leah's my partner in crime. I think
Sheila Green-Shook, Washington State Health Information Management Association.
Great. Glad you could join, Sheila. Anyone else? Hi, Ian.
It's Ian.
Ian, I hope you're not driving.
I'm not. I'm sitting in a parking lot, but I'm definitely in vacation garb. Representative Schmidt laughing at me, probably.
Other folks who want to say hi. Okay. Well, good. Let me just pull up the agenda so folks know what we're going to be talking about today. So I wanted to first turn it over to Lori and let her give a little description about the Legacy Health System, and then specifically maybe let folks know what Legacy is up to in the telehealth realm. It's probably been 2 or 3 years since we started the collaborative where we heard what you're doing, and sounds like you're doing a lot of new things. So I think folks would really like to hear what you're up to.
Sure. So Legacy Health System is a 7-hospital system in the state of Oregon and Washington. We do have a collaborative with the Unity Hospital, so that's not really our hospital, but we're a partner. So that would be the 8th. But we do have telehealth services in all of our hospitals. And we have 26 primary care clinics and a variety of specialty care clinics in the area. We're about 10,000 staff big. So that's a little bit about Legacy. For telehealth specifically, I think most of our expertise has been within our hospitals. So leveraging our specialty care with our specialists in the hospitals to extend to our internal hospitals as well as our external hospitals in some of the more rural parts of the state. So that's been interesting to develop. More recently, we have started to develop some ambulatory connections, so more in the clinics, in specialty care with things like cardiology and MFM and genetic counseling, and extending even further than that to patients in their home, most recently with primary care video visits. The hope is that we will continue to extend the video visits with other specialties as well to patients in their homes, not necessarily in a clinic. And hopefully we'll start doing some home monitoring work soon, looking at how we can identify some vendors who are compatible with our electronic health system or electronic health record system. Yeah. More to come, hopefully the next year.
Great, thanks, Lori. I'm wondering if I could put you on the spot, and if you wouldn't mind sharing one learning with the collaborative and maybe one challenge that you'd like to see maybe this collaborative tackle in the next year or so.
Oh, sure. I think it's really exciting to get programs or services off the ground. There's a lot of energy around that within our health system, but I think the challenge really is to keep those services going, continue to evaluate the quality that we intend those programs to have for years to come. So I think that's a challenge because of the resources that we have in healthcare and the rate that everybody wants to expand the service. So that's the challenge. I think there's an opportunity from just our experience to collaborate more with some of the payer groups, because I think there's sort of a gap sometimes between what we think a code should look like and what payers define codes. So I'm also part of the Telehealth Alliance of Oregon, and we're going to have a panel at a conference on May 13th, working with some of the payers and some of the folks that provide the service to try to see where those gaps are, at least start the discussion.
That's great. So that's May 13th, just a week from today. Yeah. Okay. Would you be willing to update us at the next meeting, kind of from learning that you have from that? That'd be really helpful. Yeah, so the OTA, or Oregon Telehealth Alliance, is
Telehealth Alliance.
Okay, sorry, I missed it. I think that's probably the Oregon analog of the collaborative.
Right.
Okay. Well, great. One other thing that I wanted to share with folks that that Lori and I were talking about beforehand was, Lori was wondering if there are technical resources, and I wanted to remind her about the Technical Telehealth Resource Center. It's called TTEC, or TETRIC, and it's based out of Alaska. They offer 10 hours of free technical consulting, and I think we're trying to get them to come to one of our meetings to just educate us a little bit more. But if you had a question about which equipment I should buy, that you don't have to do that all yourself. that's a resource that people can take advantage of. Great. Well, thank you very much. Anything else you wanted to add? Or
I just think we're thrilled to host the collaborative, and thanks for everyone who took the time to drive on down to San.
Great. All right. So the next thing that's on our agenda is to give an update of the American Telemedicine Association meeting, which was mid-April in the city of New Orleans. And I'm going to kick things off and hopefully see if Danny and Cara can add in what they learned from it. It's a big meeting. It's about 4,000 people. The conference center itself was about a half-mile long. So it was one of the biggest conference centers we've been in. And I think there were a couple of themes of the conference. The first was that there's a lot of conversation about AI, or artificial intelligence, and how that's going to increasingly be a part of telehealth, specifically when you start doing things like remote monitoring and just automating things and things like that. So there's a lot of sessions talking about the ethics and the legal issues surrounding AI, and especially the applications. There was a very interesting presentation by Boston Children's using voice-activated AI. So think of like Alexa and how that can be used for healthcare. They have found out that the quality of your voice can diagnose certain conditions, certain diseases. Obviously, the one that comes to mind are mental health conditions, but even other conditions. So they have a whole strategy around using voice in their healthcare system. That was a very interesting talk. There also was a session by CMS that I found very helpful, and I wanted to share some learnings from that. So first of all, I just wanted to let you know of some new codes that CMS has released. And there were about 3 or 4 that were pertinent to that. The first one is a G0513 and also G0514. It's the prolonged services, preventative services code. And so this is like if you're using telemedicine to talk about colon cancer screening or following up a cholesterol screening and things like that, that is now being reimbursed without some of the usual restrictions that Medicare has, like on geographic location. There's also the virtual check-in, which is a G2012. This is a brief communication. Hope they were kind of pitching it as 5 to 10 minutes. And you can only do that if it's more than 7 days out from an office visit. There is now remote monitoring codes. So this is G2010. And so this is for the interpretation and setup of remote patient monitoring, and a couple other codes associated with that, 99051 and 99451 and 99453 through 7. A couple things I would say about a lot of these new codes, they're especially for established patients, you need to have consent. And in some situations, the patient needs to initiate the visit. So it's going to be worth your while if you want to do this to really read what those specifics are with the code. And then the last thing I wanted to talk about were some of the plenary sessions. So one of the plenary sessions was the CEO of Best Buy. So Best Buy acquired the Geek Squad, and they're really envisioning the Geek Squad to be total tech support, and they're partnering that service with a company called Great Call, which is, I guess, is a telemedicine company, and they're really trying to help people live longer, independent lives. So basically, the whole idea of a hospital at home or more of a nursing care at home, where you can have some of the services being done to your home, and the Geek Squad guys are helping with the technology of that. So that was an interesting plenary. And then the final day plenary was with Toby Cosgrove, who's the CEO of the Cleveland Clinic. And I think the things about that struck were his take on the healthcare system. He, like a lot of other people, said that the healthcare is too expensive. The number of hospital beds is going down, so more and more healthcare is being spread out to the home or to the clinics, and that we're really in this time of moving from fee-for-service to value-based care, and it's just going to take a while. But he feels like telehealth is going to be a big play for the value-based care world, and he's working with Google and their Google Cloud application. So that was some of maybe the takeaways I had from the meeting. I want to see if Cara or Denny had some other presentations that they went to that they felt were maybe helpful for other people to hear about. Cara or Denny, do you want to say anything?
I'll just apologize that I have not had a minute to sit down and sort of digest everything that I got from there. But just from a general perspective, as you know, John, I think the ATA conferences seem to have changed, and it's still a few sort of providers of telemedicine services who are sort of giving a show and tell of the things that they're doing and what worked and what didn't, and that kind of stuff is helpful to me. A lot of it, however, now does seem to be national companies or new startups, things like that are trying to get into the telehealth space. And so I just, from a general picture, big picture, I thought that was really interesting, that it's really taking off in that direction.
Yeah, that's a good point. Danny, anything that struck you from the New Orleans meeting?
I think the only other thing I would add is that there seems to be more interest, a growing focus on telehealth interoperability, and I haven't had a chance to review that paper yet, but it looks like that's going to be one of our new areas of focus as well.
Okay, great. Well, I do want to let folks know that Sarah Orth represented the collaborative ATA. She did give a 15-minute talk talking about the work of our collaborative, and I think she got a lot of questions and a lot of interest in that, and people really thought we were doing some cutting-edge stuff here. So you all were well represented by Sarah, and I thought that was a helpful session to attend. If you are interested in other telehealth meetings, but you can't make it to the ATA meeting, I just want to remind you that there will be a regional telehealth meeting that the NRTRC is putting on, and that's going to be in Anchorage, August 26th through 28th, so a little bit closer. It's a little bit cheaper. I think the registration is around $200, and it'll be smaller too. It's instead of 4,000, it's anywhere from 200 to 300 people. So that's, I just want to let folks know if you're interested in this and want to take a deeper dive, it's a great conference to attend. So the next thing I wanted to move on to is to talk about how the collaborative is doing on its web presence. I think there was a question last time about the Google Analytics. So I'm going to pull up that's for y'all, and I can show that. So here it is. Okay. So we're averaging about 100 to 200 visitors per month to the WISHA hosted site for the collaborative. And it seems to kind of spike. I haven't really mapped it out if it's spiking with when we're having our meetings, but it seems to have a little bit of variability there. And the other thing that WISHA ran.
That's okay. I'm just.
Say that again. Okay. So then the other thing I wanted to share with you was we have it by city. We have the number of page views. So there was 292 page views for Seattle, followed by 285 for Olympia, 104 for Renton, 42 for Tumwater, 15 for Redmond, 9 for Shelton, and then Shoreline, Clayton, Puyallup, Kennewick, Omak, kind of in the single digits. So I thought it was a pretty good representation around the state.
Is there any analytics about what people are looking at specifically?
Sure. I don't know that. We can drill down. Yeah. So Midori at Wisha said she's happy to take a deeper dive. I think the important things were just total numbers, time, and then where are these people? Are there other questions that you'd like to ask Midori besides what are the actual pages, the actual items on the website that people are looking for?
Hey, Dr. Scott, this is Denny. I'm just wondering if there's any way we could get more of a visual-facing focus on the initial page about telehealth or the collaborative.
Sure. So the landing page you're talking about, Denny?
Yeah, it seems like you really have to hunt for it or do a search on telehealth to find it. And if you're lucky, you land there.
Yeah, I agree. It really is buried within Wisha.
Particularly as we have a pretty valuable tool we're getting ready to put up.
Yep, I think you're totally right. Yep, and I'll send out all these Google Analytics as a follow-up from our meeting today. There's their Excel, their PDF, so you guys can kind of look at what they are. But I thought overall, you know, we've had well over 1,000 views. That's pretty good for the first last. That's just in the last year. Okay. Any other questions about the Google Analytics of the website? Okay. Great. Well, Stafford, would it be okay if we ask you a little bit about what happened in the legislature this year? And before we do that, I just want to see if Senator Becker was on the line. Senator Becker, do we have you on the line? Not yet. Okay. All right. So maybe Stafford, you could kick it off. I know that a lot of the action was in the Senate, and then Representative Schmick said he'd be happy to add detail as well.
So I have prepared here the 4 bills that were sponsored by Senator Becker that deal with telemedicine. And these were the most directly related to telemedicine. 2 of them passed, 2 of them did not. The first one is 5385, dealing with payment parity. This one was discussed in the collaborative and received different thoughts. It ultimately did not pass, but the bill did evolve, and I think it's telling of where the bill went to with different stakeholders and what the legislators thought. This did pass the Senate 46-2, but it did not come for a floor vote in the House, which is why it didn't pass. This bill required payment parity for telemedicine, but it allowed for facilities or groups with 11 or more providers to negotiate a different rate. And it also left the facility fee to be negotiated. There was also discussion about store and forward technology and how that would be related to parity. And store and forward technology was left out of the parity in the language, but rather left it to be discussed by this collaborative here to have recommendations to come later. And it also removed the requirement that services be provided, or when services are provided through store and forward, there's associated office visit. That was another recommendation from this collaborative. So I think the bill got to a good place. I know there are a lot of different opinions. It didn't pass, but I think that's something to work from coming forward. The next bill, also sponsored by Senator Becker, 5386, deals with telemedicine training. The final bill, one that passed, and the governor did already sign this one, is that training may be completed. And if training is completed, then you must attest and sign that you did that training. I know there was a lot of discussion with different parties here of the attestation, record of it if you did do the training. But I think what was ultimately agreed to was the providers who do telemedicine training may, and that word may instead of must, receive the training. And probably maybe even more significant is the second part of this bill that requires this collaborative to develop training which, as we reviewed previously, I believe is already in the works and done, and it's
Almost ready to launch. Yep.
and it directs what needs to be in that training. But what needs to be in that training came from this collaborative of best practices, current law, etc. And then also there was language requested that the training be incorporated into existing trainings so long as it meets the minimum requirements, and that was specifically put into the bill.
I can figure out.
Any questions on those two before we keep moving, or should I keep going?
No.
Actually, just a quick question. Is there any commentary on why must was turned into may? Just
I don't know the exact on that. I know there was a lot of discussion in different parties. It seems like, I know we met the last collaborative and asked for recommendations, and the senators got different recommendations on what it should say, and Senator Becker made that. And I don't know the exact source, but it can certainly.
I can tell you that from a physician's perspective, there's been a lot of required training, so like the suicide, the opioid, and I think there was just a feeling kind of overwhelmed of all the training, so I think that was probably where some of the physician groups were feeling like this is just too much.
I also, this is Cara, I also talked to somebody who has a lot of connections in rural Washington, and she said that there was a lot of pushback from the rurals who had been doing telemedicine for a long time and felt like that was an extra thing that they didn't feel it should be required. So that there may have been some pushback from that angle as well.
Okay.
Perhaps.
Dr. Scott, this is Ian. Sorry, my audio was kind of cutting in and out there. So, but what Carr said and the previous speaker said are exactly why the must became a may, just to provide more flexibility.
Perhaps some guidelines might be from this group moving ahead, what I think would be appreciated.
Guidelines for
training.
Yeah. There is no other state that requires telehealth training. So we were a little bit out in front on this one.
Well, that might be why guidelines that we could put together, I think, would be accepted.
Moving on to 5387, this is the physician telemedicine credentialing. The law already allowed for privileges to be shared between originating and distant site hospitals and telemedicine. This bill is very simple. It's only changed 8 words and add credentialing in addition to privileging for distant and originating sites, to rely on credentialing in addition to privileging. 5389, this was Senator Becker's telemedicine, telehealth to treat mental health in schools. This would create a training program for all school staff, including classified staff, bus drivers, and those that interact with kids and aren't necessarily teachers, to train them how to identify students who may be at risk for suicide or harming others or mental health. So the first part of that bill would be the training, and the second would be to provide a treatment source for those students who are identified. So students who are identified have access to treatment, and the bill would specifically include 2 visits with a psychiatrist through telemedicine, and the visit is to be facilitated at the school, at a location in the school and during school hours. What happened with the bill is it passed the Senate 45-2, but like 5385, it did not get a vote in the House. It didn't come up for a vote, so it didn't pass. However, Senator Becker did work it into the budget. So the budget includes a provision similar to this, and I know Ian worked a lot on that. So Ian, if I get anything wrong, let me know. But so this is the law for the next 2 years at least. There's $500,000 was allotted for each of 2020 and 2021 for University of Washington Department of Psychiatry and Behavioral Sciences, and also Seattle Children's Hospital. And they are to do a pilot program with this. So they're going to develop the training and provide that training, but it's limited to only 2 school districts rather than statewide, or to 6 school districts like the original bill wanted to get. And then It's going to take time to develop that training and to give that training. And so it's only going to be implemented in those two schools, in those two school districts, excuse me, for that second school year of this biennium is what it's funded for. Senator Becker thought this was a success. She was real happy this got into the bill to get something like this going and to get it started. And it only applies to junior high and high schools in those school districts, not elementary schools. Do you have anything to add, Ian, or is that pretty spot on?
Well, other than I just realized halfway through that was you giving the presentation, Stafford. So you couldn't do better than, or I couldn't do better than you, that's for sure. Stafford's also not mentioning the fact that he worked extremely hard on getting the proviso in the budget that Senator Becker pushed for to try this out in at least two school districts. And it was my understanding through Senator Becker that Senator Rolfes, the chair of the budget committee, was also very interested in making sure that that funding was there, and that's a huge reason why it is there. So Dr. Robert Hilt, who oversees child psychiatric care through the Partnership Access Line at Seattle Children's, is going to be deeply involved in this pilot, and I think it's got great potential. But we'll have to take the funding and see how it'll work. So I know his team and Dr. Unitzer and others are already hard at work trying to figure out how we'll implement that. But it was a good victory at the end of the budget process. And I apologize because my audio was breaking out. It sounds like Stafford already covered 5385, which was the parity bill.
Yep.
Just a matter of didn't get it on the run sheet in appropriations, and Representative Schmick, that was definitely something that I got to too late, and others got to too late to try to get to you and others on appropriations to get a hearing for that bill. So we'll be at it again next year. But as far as I understand, because that was something we had worked out in the end between the carriers and the providers, that we were in good shape. It was just, as Representative Schmick knows better than anyone else, that when the clock runs out, the clock runs out, and bills die for no other reason, then you just don't get it on an agenda.
Didn't go through, it helps if it would have gone through healthcare. Secondly, there are carriers who are still pushing back from moving this ahead. And because of that resistance, then you'll find things don't always go as you'd like. But there are carriers who they have not embraced telemedicine. So it's just a barrier we're gonna have to work through so that they can see, I think, a balance in equity, and that there's a benefit for them to utilize it, but we're gonna have to work our way through that.
There's a question that came in through the chat function. Are there any recommendations on how we could maybe revise 5385 to get both Senate and House approval on specifically 5385 for payment parity? Do we need to tweak it some more? Is there more conversations?
I just think we need to keep working at it. There has to, the carriers, for them to buy in, they need to see a benefit. That if the care is getting out at a price that they see a value in. And we just haven't gotten total agreement on that just yet.
Right. Representative Schmick, anything else, and maybe just in general healthcare? I know there was a very active session in the healthcare, obviously around mental health. Anything else you want to kind of throw out there that maybe telehealth will touch?
I think that there, especially and when I talk about rural areas, I'm not talking just Eastern Washington. There's a lot of rural areas in Western Washington also. The legislators as a whole, they want to see this go faster and embrace it. We've just got to get over some of these hurdles and to get something in place. It can't come fast enough.
Okay, that's good to know.
In again, rural areas, and that would be defined as where Senator Becker used to live in Eatonville. I mean, there's just not a lot of services out there. So it's not just Eastern Washington, it's Western Washington also, and Eastern Oregon, as you're working through.
We're with a partner there, yes.
Mm-hmm. Okay, great.
Just have this is Brody, just a quick question about the telehealth in schools. Is there these teleconsultations, are they happening with students in the schools? Is it happening when the student is at home? I'm just kind of curious as to how these sessions are actually being administered and how they're, I guess, in some ways making some kids do these things. So.
Well, there was a section of the bill that requires consent in accordance with consent laws. I guess around enforcement. And the bill dictated that the visits would take place during school hours in the school, and the schools would need to provide a space and technology for that. I think the idea was to have a school counselor or a school nurse that would kind of be the liaison to facilitate that. And then if they need to go beyond the 2 visits, then there's a list of providers, available providers that would need to be provided for that student if they needed to go to a 3rd or 4th visit.
Thank you.
And there's also one segment of the payment from the bill that I guess I didn't touch on. The bill did dictate that the health insurance carrier for the student would pay for the visit. But if students didn't have insurance, then it would need to come from a state fund, a separate state fund that would pay for those students.
Do you know what 2 counties are going to be, or which 2 school districts are going to be up for the pilot?
I think I'd refer to Ian as he's involved with the University of Washington on that. I don't think they've been decided yet. I think it's been left up to UW in consultation with the Office of the Superintendent.
So the language on that, Dr. Scott kind of bounced around back and forth. There was some very specific language at one point outlining 2 specific school districts, Belfair and Walla Walla, I believe. But then the final language ended just with one on the east side of the mountains, one on the west side. So I think that's to be determined. Brody just hit on I think a really big point that the collaborative needs to be aware of. One of the other things that the legislature did was they put out, there's a work group that's going to be formed around this concept of reimbursement when it comes to a program or a pilot like that mental health in schools, or for that matter, reimbursement and payment of services for something like the PAL program, the Partnership Access Line at Seattle Children's. I think some legislators are concerned that state money is being used and that individuals who are commercially insured are not Medicaid insured are accessing those services, which is a good thing. But there's a question around reimbursement for those services. So a work group's been formed as a part of the budget to work on that issue of how do you reimburse for these consultative models in a fair way that is not gouging the carriers, but at the same time is not reliant solely on state funding. I think part of that will be, you mentioned Dr. Scott, and I know Representative Schmick knows all about this because he was a supporter of it. Part of the behavioral health reforms that he and his colleagues put into place include this concept of a telebehavioral health call center. You've all probably read about the behavioral health teaching hospital that the legislature is going to fund at the university to both take some patients out of Western state, but also train behavioral health employees, students. Part of that is a 24/7 telebehavioral health call center that Dr. Initzer's envisioned, where primary care, emergency room docs, and jail and detention facility docs who don't have expert psychiatric care available in their locales will be able to call this service. The question will be, how does that get paid for long term? The state is going to pay for it in the short term, but some of Representative Schmick's colleagues and others want to look further into how does this get paid for long term. So I think that's an issue the collaborative will definitely have a role in.
Okay. I did want to correct, I stated incorrectly, 5385 did go through the healthcare committee, and it got stalled in the appropriations committee.
Okay. Well, great. It sounds like in terms of follow-up for some of the bills that were proposed in this last session, that taking up this issue of Storm Forward, and since that was part of 5385, I think we kind of talked about that before and kind of remember that we thought Storm Forward was different than the live face-to-face, but we can come back to that and see if there's more of a nuance there that maybe we're missing. And then with regards to 5386, the telemedicine training, as Representative Schmick said, maybe some guidelines for training. And I'm just wondering, is there an opportunity to interface with this reimbursement work group that I think Ian mentioned, or that Stafford, you mentioned, the reimbursement work group for mental health?
I think that was Ian that mentioned that. I'm not aware of it.
We're still going to have to go through and come up. I'm sorry, Bree.
No, please go.
We're still going to have to come up with something that's on payment parity. Something that the carriers will see a value in, that they can support. Otherwise, that's still going to be the issue, I think, moving forward.
Okay.
I'm sorry, Brody.
Just from my understanding, the coverage for telehealth-based behavioral health is something that's in our plans, with the exceptions of some large employers carve out certain benefits as they have the rights to do. So, but for the most part, I'm not concerned about a coverage aspect for those that have the need.
Okay. Great. Any last questions about the last session? Stafford, I know there's often an opportunity in the fall to have a little bit more deeper dive with the healthcare committees. Is there plans for doing that again, like around November?
Yeah, in November there's going to be committee days where the committees will get together and meet, and they'll do different reports on work groups. They're not going to hear bills at that time, but they do work groups and present you with information on what may be coming. So it may be good to get something.
Okay. And then next year is a short session, right? This year was a long session. So
right.
Yeah. Okay. All right. Well, great. So next thing I think on our agenda, I actually skipped over it, was just to go over the last committee meeting minutes. That's from March. So please let me pull that up, and we need to get those approved. The folks in the room, that should be in front of you. There you go. Slow computer today, I apologize. Well, we talked about the telehealth training, and just an update on the LMS module. Joelle told me that we're within days to maybe at the most a week for that to going live. I've heard a rough draft of it. I think it's really, really good. So the Washington State Nursing Association is going to host that. So that should be going live. We heard about the palliative care project the Department of Health had sponsored and that Jenny Warden was involved in. And then really a lot of the time last time was talking about future directions and objectives for the collaborative. And that's what we're going to dive back into later this meeting. Are there any changes or edits that folks want to make to the minutes? And let me, for the folks who don't have those in front of you, I'm just going to blow that up so you can see. Let's just scroll through it. Okay, we do have a motion to approve through chat, and whoever that was, can you please just say who is moving to approve this? You can even type in your name. I see a phone number.
Well, I will so move.
Okay, thank you, Representative Schick. Do we have a second?
Second.
Second, Brody. All in favor, say aye.
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 Okay, anyone not in favor, please say nay. All right, this is passed and will be posted to the Washington State Hospital Association website for folks to peruse. So the next and last thing is to go over what we talked about last time, and those are some of the future directions of the collaborative. And I think we kind of put it into maybe 3 or 4 different buckets. There are folks who are interested in the collaborative taking on more of a research direction, specifically around efficacy and cost effectiveness. There were folks who are wanting to have a little bit more of a consumer or patient focus to it. I'm trying to remind myself what the third group is. We're going to come back to some of these things. There were a couple of action items, and I just wanted to see if people had any updates on the things that were discussed last time. And I really apologize for how slow my computer is being today. I have the spinning wheel of death right now. So please be patient.
Did I just lose you?
No, there it is. I got it, finally. All right.
This is Brody. I just have some thoughts about the, I was thinking about this earlier today about how we could better understand the incremental value and limitations of everything that we add on to the, I guess what we could call the basic platform of telehealth. There's a lot of devices that are being suggested that can enhance the telehealth experience, and not to really look at any particular device in particular, but I hear just in general conversations that, it is possible to diagnose certain things without devices, but yet there's the introduction of a device that can do the same thing. And so I'd like to really understand when devices are brought into, the basic telehealth visit, whether there is actually incremental value there or not, and if the value is worthwhile. Like I hear on both sides that in some cases you could diagnose strep throat without a lab test, and others you don't need one. And so that's just kind of the line of thinking. I mean, especially as reimbursement conversations continue, that incremental value piece becomes pretty interesting. Even the difference between video and phone. What's the incremental value of being able to do the video part versus not? And maybe even generalists versus specialists, in the sense that clearly there are certain things that dermatologists can do that like a general practitioner cannot, but when put in the scope of a phone or video visit, is there much of a difference from that perspective? I don't know the answer to that. These are all questions, but it all kind of fits within the realm of incremental value of things that are put on the platform.
So it's not just the what we call peripherals, so that'd be like the e-stethoscopes, but lab tests that sometimes can be added on.
Yeah.
Sorry, did someone want to make a comment about really patient engagement and patient perspective? Right. And Brody, I think one of the action items we had from last time was you said that CAMIA can do a survey of patients who've had a telehealth visits. Any further progress on that, or any?
We're ready to go. It's just we need questions, and so I guess where it may have been lost in translation was that we're not suggesting that we're going to do one, but that we can facilitate that. We can turn around a survey within a couple of days of like over 1,000 respondents. So if there's certain things that we wanted to test or learn for people about preferences or barriers, we can turn that around pretty quickly. So it's actually more of an offer rather than saying, hey, we're doing an actual study.
Okay. So I guess one thing, maybe the collaborative, what we could do as an action item is come up with a couple of questions that could be sent out in that survey.
Yes.
That'd be helpful.
Yeah, yeah.
Okay. Any initial thoughts on that? What would be useful for, I mean, Brody threw out things like barriers, reason to using it. Anything else, Lori?
I think particularly for video visits and the utility of, I guess for us, we found that for video visits, sometimes it's the hour of the day that's most popular. Sometimes is it your provider, is it not? So maybe if there's a way to see what the priority for the patient is, the most value that it could offer, what would that be? Would it be convenience, personalization, something like that?
Sure.
How do you distinguish between convenience and outcomes?
Convenience, so I was thinking.
Well, convenience, that's pretty easy, but what about outcomes?
So outcomes, I think, are a little bit more tricky, especially with video visits. And I guess it might depend a lot of times on maybe the specialty that you're looking at as well, because primary care would probably be very different than behavioral health, would be different than cardiology. So maybe if we could scope it and then look at is that what?
And there's a variety of outcomes, Representative Schmick. You could talk about clinical outcomes, you could talk about financial outcomes, right? So one of the things we do when we do surveys of our patients, we ask them, what would you have done if the service wasn't available? And we track what percent would have gone in the emergency room, what percent would have gone urgent care, which are higher cost items. That's a kind of a question that you probably could ask for this, and that might get at a financial outcome. I mean, just asking them, is your problem resolved, your clinical problem resolved?
Because I think that all feeds into the question about payment parity.
Yeah.
Whether the face-to-face is the same as over whatever device we have would help move that ball down that.
Yeah, so looking at, I mean, could you even ask the patients, do you feel like you got the same care through video visit as you would if you were seen in person? What do you think about that as a question?
Well, we're going to have to broach that somehow in my mind.
Yeah.
So we look at, I mean, from the convenience perspective, you can get patient satisfaction numbers, right? So as long as they're satisfied with their experience, then you can say that convenience was solved for. From Dr. Scott, as your perspective, the resolution rate. I shared our stats before that as of 2017's data, we looked at after every telehealth visit as to whether there was another in-person visit for the same diagnosis within 7 days with any doctor, not just the doctor they had the telehealth visit with. And our resolution rate was 93%. So less than 7 or less percent of visits actually had a same diagnosis in-person visit within 7 days of the telehealth visit. We refreshed it with our 2018 data. It's now north of 95%. And so,
meaning 95% do not
have a
follow-up.
Yeah, so I guess that's our proxy for resolution. We don't know for certain whether they felt it was resolved, but they didn't actually go far enough to say, oh, this didn't really serve my need. I'm going to go in and get it taken care of by somebody else who can, whether it's urgent care or a doctor. So we're pretty confident about the resolution rate. I guess to build on my comment, Representative Schmick, was the incremental value of the devices. So let's say we have payment parity on the visit, but then there's, a belief that, hey, the health plan should now cover for the e-stethoscopes. They should now cover, all these other peripherals, or if a doctor uses an e-peripheral from the patient, they should get reimbursed for the actual, work of doing that. Then all of a sudden these little things start adding up to be more than an in-person visit. And so we're just trying to figure out, is there incremental value of these additional things in addition to the core based health? So that was kind of the root of my comment about these incremental.
Well, I understand that, but then the question, then do we try to define that? I mean, that's the next step of it. That's why I kind of think we're going to have to define some of these things.
Yeah.
In order for this to take hold and for buy-in as it goes ahead.
Yeah, I mean, my personal thought is things like stethoscopes and otoscopes and things like that. I mean, you don't pay for my stethoscope that I use in the office or otoscope. I mean, that's just kind of considered overhead. But if I order, like say, a urinalysis, that does get added. And there are telemedicine companies where they'll express ship out a urinalysis strip. The patient gives a urine sample, and then they take a picture of the UA, so they really know this person actually has a UTI. And that's an example of how I think that really does replace that. So is that kind of where you're thinking about those kind of?
Yeah, like I don't necessarily have a position on anything right now. It's just more so that now when you have the basic capability in place, there's all these capabilities now to augment that with other things, and just trying to really understand what the value of those augmentations are.
Again, I just think the carriers need to see a value for them to embrace it.
You're right.
Dr. Scott, this is Kathleen. Can I add a comment?
Is that Kathleen Damon?
It is.
Oh, great. Glad you could join us.
Thank you. Sorry, I had an overlapping meeting. I did want to add that we did a retrospective study looking at this is from Swedish Medical Center, looking at the admit diagnosis versus the discharge diagnosis and how close the two were from telehealth hospitalist admits. And that was a very clear indicator of accurate initial diagnoses, and one of our physicians actually presented and did a paper on that, and that was I think he was like 96% with and I think that had an N of about 375 patients at the time. So that's a great way to look at diagnoses. And also I think to the speaker, who's the nice gentleman that I can see on my screen on the right hand side with the dark suit and the
Brody. That's
thank
Brody.
you. Sorry. Hi, Brody. We also have looked at a satisfaction survey that we've used over a number of years, providing 7 questions to the patients. We have one for providers, one for the physician on the patient side to see how that was a resolution from the patient side, from the provider delivering the service, and also from the telepresenter perspective. And there are about 7 to 10 questions, I believe. And the questions cover everything from, was this the same or better than in person? And that kind of specific questioning around telehealth, not looking at the medical care per se as much as how is the delivery model and what kind of responses we got from the patients.
Okay. Thanks, Kathleen. Kathleen, as a follow-up, would you mind presenting that information at a future collaborative meeting?
Absolutely, be happy to.
Yeah, I think just getting some of those details are helpful.
Yeah, absolutely. I'd be happy to do that.
Great.
And Dr. Scott, this is Denny, and this question might be for Brody, but I'm wondering from a payer perspective, what's more important, is it patient satisfaction or outcomes, or some combination of both? What's your take?
So I heard the patient satisfaction. What was the other?
Or clinical outcomes.
Yeah, it's yes is the answer.
The answer is both, Denny. Maybe, can I call on Cheryl Huchala? I'm wondering if, Cheryl, you could maybe share the Primera perspective, and we're talking about value of telehealth, and what kind of data are you guys looking for to maybe make the case for telehealth?
Yeah, we haven't analyzed the data in the way that it sounds like Regent has. Oops, I'm sorry. Can you hear me now?
Yeah, go ahead.
Sorry, had the mouthpiece turned away. We haven't analyzed the data in the same way that it sounds like Regents has, so I'd be curious to see if we're seeing some of the same kinds of things or not. And I agree with Brody when we talk about outcomes or patient satisfaction. We want both. I think the hard part with patient satisfaction is every member has their own definition of satisfaction. So
Right.
sometimes that's a difficult thing to measure.
Right.
It doesn't mean we don't want to capture it, but it's a hard thing to come to define in black and white because everybody sees it differently.
Okay. Great. So I think we have 2 action items here. One is please come with 1 or 2 questions that maybe we could submit to Brody to ask patients. And then the other is we'll ask Kathleen to present the 1 or 2 studies that she had mentioned. So the other subcommittee we talked about was research. And that was something I think Chad Gabelin and Sarah Orth were going to try to champion. And unfortunately, we don't have either one of them on the call today. But Chad was going to follow up with the Benaroya Research Institute and see if there was anything that they could land their expertise on. Now, that you guys should know that there is a HRSA-sponsored Center of Excellence for Research on Telehealth. It's based at the University of Iowa, and they have presented in prior ATA conferences. So that might be a place we'd want to kind of see what's on their website and what kind of things they're looking at. So that's, as we start to dig into that a little bit more, it's a great resource. Then the other committees that I was just reminding myself is an advocacy committee, which people were talking about doing a gap analysis and helping CME. Just, I think here, it was not so much advocacy of like payment parity or anything like that. It's just, I think people were saying we want to get the word out to patients and to providers that telehealth is an option. So that was the thinking there. And that was something that I think Joelle was going to follow up on. We don't have her on the call today. And then finally, the last committee was a payment model subcommittee. And Marissa, I know that's something you were interested in. Do you have any other further thoughts about how this could maybe take shape? Marissa Ingalls from Coordinated Care.
Hi, Dr. Scott. Yeah, this goes back to the comments that I made about Healthcare Authority in particular, emphasizing a shift over to value-based payments. So anyone who has Medicaid patients, your contracting team has likely heard from managed care organizations in some way or another, or will be, and understanding how telehealth fits in that would be extremely helpful as the as the state of healthcare continues to change. And I think it relates back to some of the other topics that were previously discussed that Brody brought up about, adding on things like, I guess, remote testing kits or just how the world is changing away from fee-for-service.
Okay. Yeah, and these risk-based contracts, value-based care contracts. I mean, that's where I'm seeing a lot of the innovation in telehealth. It's places like Kaiser, places like Mercy that are doing more of the remote monitoring and doing more creative work because they can.
I do have a question. I don't know if anybody can answer it. Do the managed care organizations who currently have the contracts to deliver, are they embracing telehealth? I don't know that.
So Representative Schmick, this is Marissa again. I can only speak for Coordinated Care. We do have a contract with Project Echo in place that Dr. Scott is familiar with. We will also be rolling out another platform called Teledoc to the state. Like I said, I can't speak for the other MCOs.
Yeah. I know that Molina is definitely interested in this.
Well, I guess my question is for the Healthcare Authority, whether or not this is included in the contracts, because I imagine they're very similar, those contracts as they're awarded. I don't know that answer to that.
I don't know the answer. Does anyone else? If there's anything in Healthcare Authority, specifically like a policy around telehealth?
Well, it would be in that contract.
That is not something I'm familiar with.
I'm sorry, this is Stephanie from CHPW. I know that this is implementing telehealth, especially around telebehavioral health, is something that the Healthcare Authority is tracking. They actually just sent out a survey to all the MCOs to get more detailed information about what we're doing in terms of implementing telehealth. So I don't know if you guys are interested in specifics from each organization. CHPW funds MAVEN, the MAVEN project for our providers, and kind of different MHIP. We have kind of different ways that we're implementing telehealth.
How proprietary are some of those things? Is it? Can you share some of those policies that are entailed in a contract?
I think I would need to check, but I think our contracts are online.
Okay.
I mean, I think there might be some contract information that's public.
Okay. Stephanie and Marissa, I'm just wondering if you guys, as a follow-up item, if you would be able and willing to share some of the specifics around your payment policies.
Yeah, I mean, CHPW follows the guidelines we pay for all telehealth encounters.
Okay.
According to the WAC.
Okay.
Yeah.
Okay.
Yeah, we were actually neutral on the payment parity bill. I know that doesn't actually help because the bill didn't pass, but we would have been fine seeing that pass.
Okay. Good. All right, well, those are the committees that were proposed. One of the other marching orders of the collaborative is to hear about new ways that telehealth is being deployed. And I was wondering if people wanted to hear more about AI and how it's being applied to telehealth. Just kind of some of the things I was learning about at the ATA meeting. It's super interesting. It's incredibly complicated when you come to a legal and ethical issue. But I think that the collaborative might be really interested in learning a little bit more about that. If that's something that people want to hear about, I'm happy to prepare that for next time. Okay, good. I've seen some nodding of the heads. Great. Other things that people want to discuss at upcoming meetings, I think we've got a number of follow-up items, but anything else, and I will open it up to the public at this point to see if there's things we're missing, things that you want us to discuss. Anyone online?
This is Stephanie from CHPW again. I'm interested in understanding where providers are in terms of implementing telehealth and what the barriers are for them. I know that from our perspective, a lot of the telehealth vendors don't necessarily connect back to the primary care provider. And that's one of the gaps that we've seen in terms of implementing these strategies that doesn't, connect back to providers. So I'd be interested to know what providers are doing so that they can stay connected to what's being delivered remotely.
Okay. So maybe we can call out on the providers or on the collaborative. That'd be Jeff Jones, myself, Sarah Orth, Denny, Kathleen, Chad. We'll see if they can share maybe the health system or the provider's perspective on telehealth. I think that would be good, just so the payers know what's going on. Okay. Any other questions or comments? Okay. Well, good. I think we're going to end a little bit early. I want to thank Lori and her team from Legacy for hosting us today. The next meeting will be in Wenatchee at the end of June. We have Dr. Frank, who's going to be hosting us. I think Dr. Frank, Jeff Jones from the collaborative will be there as well. So we are already in the process of hooking up with you guys, and look forward to hearing a little bit more about what's going on in that part of the state. Great. Well, thanks, everyone. We will see you in a month. Take care.